What's cooking, guys? Dr. Ryan here again. Today we're talking mitral stenosis. As always, a handy clinical case. We got Mrs. Hart today, who presents to her local emergency department with the problem of acutely worsening shortness of breath. Oh dear. She is an 84-year-old woman with severe mitral stenosis who is scheduled for a percutaneous mitral balloon valvuloplasty in just 3 days' time. However, today, while cooking tasty chicken salad, yummy, she noted the onset of overwhelming weakness and dyspnea. On evaluation, she appears dyspneic and in mild respiratory distress. Oxygen sats on room air is 91%. Heart rate is 55 beats per minute. Okay. Blood pressure 110/80. She has rales to the mid-lung fields bilaterally. You note that her rhythm is irregular, oh dear, and the ECG confirms new onset atrial fibrillation. You suspect that she has a very high left atrial pressure causing pulmonary edema. Now, all of the following therapeutic interventions would probably help lower her high left atrial pressure, with one exception. Is that exception A, IV furosemide, B, percutaneous balloon mitral valvuloplasty, C, synchronized direct current cardioversion, D, transvenous pacemaker placement and pacing at a rate of 90 beats per minute, or E, all of the above will help lower her left atrial pressure. So let's get stuck in, guys. What are the causes of mitral stenosis? By and large, the most common is chronic rheumatic heart disease. And in 50% of cases, there may actually be a history or recollection of a rheumatic fever or rheumatic chorea prior. Other causes are congenital involvement of that mitral valve, calcification of that valve, usually amongst the elderly folks, and carcinoid syndrome. What's the differential diagnosis for a mid-diastolic murmur at the mitral area? Left atrial myxoma. But a key feature of this is that the murmur, the characteristics of the murmur that you hear is going to change with posture. A ball valve thrombus in the left atrium, and then, of course, tricuspid stenosis. Right, what are the clinical findings in pure mitral stenosis? Well, if you progress through the different points in the cardiovascular assessment, you can start with the pulse, which is typically low volume, normal in rhythm and character. Importantly, there's no radial or no radiofemoral delay. In terms of the jugular venous pressure, it actually may be normal. A wave is prominent if there's pulmonary hypertension which has supervened. And of course, if the patient is no longer in sinus rhythm and has atrial fibrillation, as in our clinical scenario, the A wave is going to be absent. On inspection, the patient may have the mitral facies, and we'll talk about that, and may have a visible cardiac impulse in the mitral area on inspection of the precordium. On palpation, we find that the apex is usually non-displaced. It's in the left fifth intercostal space, but the key feature is that it's tapping in nature. A thrill may be present in the apical area and is diastolic in nature. Right, the money is in the auscultation. The first heart sound is generally loud in all areas, but more so in the mitral area. In the second heart sound, this is normal in all areas, but you may have a loud pulmonary component of the second heart sound in the pulmonary area because of pulmonary hypertension. The key is the mid-diastolic murmur. You detect this in the mitral area, which is going to be low-pitched, localized, rough and rumbling. Right? LLRR. Low-pitched, localized, rough and rumbling, often heard with the bell of the stethoscope. Right? In the left lateral position. And you can often, if you can't really hear it very well, reorientate the patient to the left lateral position, ask the patient to hold their breath, and you lift and you listen just after expiration. All right. Obviously, if the patient has sinus rhythm, you're going to have presystolic accentuation of the murmur. We'll talk about that. And of course, an opening snap. So here is a phonocardiogram demonstrating what we've just discussed. So we have a loud first heart sound because of the high pressure between the mitral valve leaflets at the onset of systole. It closes with a thud, right? You have a loud pulmonary component of the second heart sound if there's pulmonary hypertension. The actual murmur is here, the mid-diastolic murmur, the low-pitched, rumbling mid-diastolic murmur at the mitral area. I mean, note, however, here, there may be presystolic accentuation of the murmur if the patient's in sinus rhythm. If you've got atrial fibrillation, you can't get presystolic accentuation because there's not proper priming of that ventricle coming from the left atrium, right? And the distance between the second heart sound and the onset of the murmur speaks to the severity, right? That is, the distance here between the second heart sound and the onset of the mid-diastolic murmur is inversely proportional to the severity of the stenosis. Alrighty. Why is the apex beat tapping in mitral stenosis? Because of the accentuated first heart sound. What is the mechanism for presystolic accentuation and where is it present or absent? We already alluded to this, that presystolic accentuation occurs during atrial systole due to the increased flow of blood across that nose valve from the left atrium through to the left ventricle. It is present only in sinus rhythm and is absent in atrial fibrillation. Right, what is the mitral facies, or what we call the mitral flush? Right, it refers to the rosy complexion of the cheeks, may even be a bluish tinge. Why do we get this, pray tell? Due to the atrioventricular anastomoses and vascular stasis in the cheeks. It's not pathognomonic. It may even be found in normal persons. Right, it's also found in hypothyroidism and polycythemia. What is Lutembacher syndrome? Right, it is a combination of our beloved atrial septal defect with acquired rheumatic mitral stenosis, and it occurs in upwards of 4% of cases of atrial septal defect. Okay, what are the different types of mitral stenosis? It all has to do with the valve area, right? The more narrow it is, the more severe is the stenosis. So mild is above 1.5 square centimeters, moderate between 1 to 1.5, and severe is less than 1 square centimeter, so-called critical stenosis. Right, what are the signs that speak to severity of mitral stenosis? So we note that the normal area of the mitral valve is about 4 to 6 square centimeters. Signs of severe mitral stenosis are a low volume pulse, right? The first heart sound, which is soft. Normally we said it's loud because of the high pressure, but here, as the stenosis gets worse and worse, the first heart sound, or the loudness of the first heart sound, is reduced. The mid-diastolic murmur, a longer murmur, speaks to a more severe mitral stenosis, right? So it's not the loudness of the murmur, it's the length of the murmur. Opening snap, we find, is closer to S2, and we spoke about that on the phonocardiogram. Signs of pulmonary hypertension, we'll speak about that. In more severe mitral stenosis, we note that the opening snap disappears and the mid-diastolic murmur becomes quiet due to the low cardiac output. What are the mechanisms behind pulmonary hypertension in mitral stenosis? I'm glad you asked. Right, so there's passive backward transmission of the raised left atrial pressure, which basically backs up into the pulmonary circulation. There's a reflex pulmonary arterial vasoconstriction, which doesn't help. And there's organic obliterative change within the actual pulmonary vascular bed. Now, what are the signs of pulmonary hypertension? Okay, a low volume pulse, a prominent A wave on the jugular venous pressure, palpable pulmonary component of the second heart sound, a left parasternal heave, which speaks to right ventricular hypertrophy. Epigastric pulsation, same story, right ventricular hypertrophy, and a loud pulmonary component of the second heart sound. Remember, as the pulmonary hypertension progresses, you may have dilatation of the tricuspid valve ring. So you might have actually tricuspid regurgitation and signs of cor pulmonale with progression, right? What are the complications of mitral stenosis? Well, up front and center is atrial fibrillation, as in our clinical case, pulmonary edema, pulmonary hypertension leading to congestive heart failure, pulmonary infarct, systemic embolism, commonly cerebral in the MCA territory, causing infarction with hemiplegia. Also, you can have embolism going through to the mesenteric circulation and the renal circulation. Hemoptysis. The list goes on, guys. Ortner syndrome. What is Ortner? It's an enlarged left atrium which exerts pressure on the left recurrent laryngeal nerve, causing hoarseness of voice. I think I sound very hoarse, but I'm sure you get the idea. Dysphagia due to an enlarged left atrium. Interstitial lung disease due to prolonged pulmonary edema. Chest pain in 10% of cases due to pulmonary hypertension. It must be noted, guys, infective endocarditis is very, very rare in the setting of mitral stenosis alone. What is the usual site of lesion in cerebral infarct? It's involvement of the lenticular striate branch of the left middle cerebral artery, causing a lesion in the internal capsule, which causes a dense hemiparesis, dense contralateral hemiparesis. What is the cause of hemoptysis in mitral stenosis? Well, there's rupture of the pulmonary or the bronchial veins with the pulmonary hypertension, something we call pulmonary apoplexy, right? And may be due to pulmonary infarct, or may actually lead to pulmonary infarct. Right, so you got a patient with mitral stenosis clinically. How are you going to go about investigating them? Chest X-ray, good idea. We'll talk about that. ECG is going to show you typical changes. P mitrale, which is actually a bifid P wave because of left atrial enlargement. You may also have right atrial enlargement and right ventricular hypertrophy. Alrighty, and that will give rise to a right bundle branch block, a dominant R wave in V1, a picture of right ventricular strain with T wave inversions in leads V1 through V3. Echocardiogram, obviously a good idea for many reasons. Cardiac cath in some cases. Coronary angiogram to exclude concomitant coronary artery disease if there are associated symptoms in some cases. Right, you got a chest X-ray in a patient with mitral stenosis. What you gonna look for? What you gonna look for? There are many features, guys. Dilated upper lobe veins is an early feature. Now, normally the ratio of upper to lower lobe veins is 1:3. This is now altered to 1:1 because of the pulmonary hypertension, the straightening of the left heart border, and fullness of the pulmonary conus and filling of the pulmonary bay because you got a large left atrium. You get curly B lines, which speaks to horizontal septal lines and the costophrenic angles. A double shadow in the right heart border speaks to a large left atrium. You get widening or splitting of the carina. You got a left bronchus, which is sitting more horizontal because that left atrium is just so large. Pulmonary edema. You also get mottling or reticulonodular shadowing due to pulmonary hemosiderosis in advanced cases, and you get a calcified shadow of the mitral valve. This is a beautiful, beautiful picture of a chest X-ray, courtesy of Radiopedia. Thank you so much, guys. So here we can see stenotomy wise. So this patient had obviously an operation before. We see a prominent left atrial appendage because of enlargement of the left atrium. Here is the enlarged left atrium here, superimposed with the right atrium, causing what we call a double cardiac shadow. There's splaying of the carina here. You can also see pericardial calcification, marked cardiomegaly. All right. So mention some echocardiographic findings in the setting of mitral stenosis. There's many to mention, right? You may have a thickened mitral valve leaflet with restricted opening because of doming of the anterior leaflet and restrictive movement of the posterior leaflet. You got reduction of the actual valve area. Sorry, this is narrow, not narrow, which happens to be button or funnel shaped. Calcification of those valves with an increased echogenicity. You have shortening of the chordae tendineae, an enlarged, big, old left atrium. Thrombus may be seen, and the characteristic M shape of movement of the anterior leaflet is as normally seen in diastole. This is lost, and the diastolic slope, which speaks to the EF, is also reduced. Right. So how do you want to treat mitral stenosis medically? So advise the patient to restrict their activity. Right. You might want to anticoagulate them to reduce the risk of embolism. If the patient has superimposed atrial fibrillation, it's a good idea to give digoxin. Now, digoxin, remember, is positively inotropic and negatively chronotropic. It's going to slow down your heart rate. It's going to increase the oomph of ventricular contraction, right? A beta blocker to reduce your heart rate, which is desirable in mitral stenosis because it allows more time for left ventricular filling. Same story with the rate-limiting calcium channel blocker, the likes of rapamycin or diltiazem. If there is congestive heart failure, you want to give a diuretic, and DIG may also help in that scenario if they superimpose AF on top of the heart failure. Amphetamine carditis is very rare in mitral stenosis. Routine prophylaxis not recommended. Okay. What are indications to anticoagulate patients with warfarin? Right. Remember, there's no role for noaxia. You want to use warfarin. So systemic and pulmonary embolism, atrial fibrillation, left atrial thrombus, LV, systolic dysfunction, right? What are indications for surgery in mitral stenosis? So, if the patient has symptomatic, if they are symptomatic, so especially speaking of dyspnea, all right, diminished effort tolerance. If you got symptomatic moderate or severe MS based on the actual dimensions of the mitral valve orifice, if they are moderate or severe mitral stenosis with moderate or severe mitral regurgitation, if they have episodes of recurrent thromboembolism, episodes of pulmonary edema without a precipitating cause. If we've got concomitant atrial fibrillation which does not respond to our medical therapy that we just discussed, if they've got pulmonary hypertension or recurrent hemoptysis, occasionally in pregnancy with pulmonary edema. This is an all not too common scenario, right, of patients who actually present with mitral stenosis or pulmonary edema during pregnancy. The surgery here is done in the third trimester as the blood volume increases significantly here with increased pulmonary pressure. What surgery do we normally do in mitral stenosis? We can do one of three. Valvuloplasty, in the way of percutaneous balloon mitral valvuloplasty is usually the treatment of choice. You go in there with a balloon catheter and you just enlarge the orifice, right? Or you can do a valvotomy, and then we have a closed mitral commissurotomy or valve replacement altogether. What are the criteria for valvuloplasty? The patient must have significant symptoms. It must be pure mitral stenosis and not mitral stenosis with mitral regurgitation, right? So obviously we can't have mitral regurgitation. Even if it is there, it must be trivial. The valve must be mobile with no calcifications, because if you're going to go in there and they have a calcified mitral valve, you're just going to cause sharding of that calcium from that calcified valve downstream and subsequent embolism. Right, and of course you must have no thrombus in the left atrium. What are the indications of valve replacement? If you got associated mitral regurgitation, if the valve is calcified and rigid, and you got a thrombus in the LA despite anticoagulation. Alrighty. What are the complications of surgery? You may complicate with mitral regurgitation, thromboembolism, and restenosis. Contraindications to surgery in mitral stenosis is if you have acute rheumatic carditis. And how are you going to address mitral stenosis in pregnancy? Advise bed rest, correct anemia, correct nutrition. If symptomatic, a balloon valvuloplasty is the treatment of choice. If this is not possible, and in more severe cases, you can undergo successful surgery, preferably in the third trimester, because remember that the circulating blood volume increases substantially here, which is going to raise your pulmonary pressure significantly. So that if you're going to intervene in pregnancy, third trimester is the time to do it. All patients should go to full term, and C-section should be done. Advise the patient to restrict the number of future pregnancies, probably to a maximum of 1 or at most 2 more. Alrighty, so everybody, here was our clinical case. We had an 84-year-old lady, Mrs. Hart, who has mitral stenosis. She's scheduled for balloon valvotomy in a few days' time, but now she's acutely weak and dyspneic, and clinically, she has atrial fibrillation. All right, and you suspect she has high left atrial pressure. What you gonna do? What you gonna do? What you gonna do? All right. So the one that is not gonna have any bearing or impact on her left atrial pressure is transvenous pacing. All right. Now, we note that the left atrial to left ventricular pressure gradient is highly dependent on heart rate, since the duration of diastole is inversely related to the heart rate. So in the setting of MS, a longer diastolic time allows more time for the left atrium to empty into the left ventricle, and thus it lowers your left atrial pressures. Hence, sinus bradycardia is actually advantageous in the setting of mitral stenosis, and inducing a faster heart rate through pacing is actually going to be harmful. The vast majority of patients with mitral stenosis are unable to maintain sinus rhythm long term, as their atria tend to be very dilated. Alrighty. Okay, beloved, God bless you. Even as we enter into a new year, I just want to encourage you with 6 things that God hates, outlined for us in the book of Proverbs, chapter 6, verses 16 through 19. It says, there are 6 things the Lord hates. Yes, even 7 are an abomination to him. A proud look, a lying tongue, hands that shed innocent blood, a heart that devises wicked plans, feet that are swift in rushing or running into evil, a false witness who speaks lies, and one who sows discord among brethren. I pray that we will live a circumspect life, being sensitive to the leadership of the Holy Spirit and doing that which pleases God, and staying away from that which incurs his indignation. God bless you. Have yourself a wonderful day. I'll see you soon with another video on this channel. God bless you.